Dr. Timothy Hughes, clinical professor at the University of Adelaide in Australia, will answer some questions regarding the treatment options for CML. Could you tell us what the overall goals and the current issues are in the treatment of CML?
Well, we achieve very good responses in patients with CML, but we need to keep in mind three key goals of therapy. The first is trying to achieve a normal lifespan. The second is trying to maximise quality of life and to, as much as possible, to achieve an excellent quality of life. And thirdly, we're increasingly looking at the possibility of achieving treatment-free remission. So we need to judge the priority for those three critical goals against each of the drugs. Now, we have three drugs generally available for these patients: imatinib, the first-generation tyrosine kinase inhibitor, and nilotinib and dasatinib, the second-generation kinase inhibitors.
What are the advantages and disadvantages of the currently available TKAs, and when addressing to those issues?
We have three TKIs currently available. The first is the first-generation kinase inhibitor imatinib. And that's an extremely good drug. It's been around now for more than a decade, and it's very safe, and we don't see any insidious toxicities emerging with that drug therapy. However, it's not as potent as the second-generation drugs, and it is susceptible to mutations. There are a number of mutations that will lead to resistance to imatinib. We now have the second-generation drugs, nilotinib and dasatinib. They're both more potent than imatinib, but they are also associated with some significant toxicities. In the case of nilotinib, we see a significant number of patients developing vascular events. Now, overall, the rate is around about 6 to 8% of vascular events on nilotinib, compared to in the randomised trial with imatinib of only about 1%. This is quite a significant difference, predominantly seen in patients who have significant risk factors, and the major ones that we see are diabetes and previous vascular events. So in the setting of those two clinical scenarios, we would be hesitant to use nilotinib as our frontline therapy. For dasatinib, it also has a concern, and that is the development of pulmonary arterial hypertension. This was recognised first in the French registry, where 8 cases were identified. But recent posters at the ASH meeting have identified up to 10% of patients who have cardiac echo evidence of pulmonary arterial hypertension. So this is an emerging problem we need to be very careful about. So I think the overall theme is that we have three good drugs, each with advantages and disadvantages. We need to individualise our selection according to what is the key goals for our particular patient.
How would you select the best frontline TKA?
When I first see a patient with CML, the first thing I try and establish, once I've established that it's chronic phase disease, is what is my priority for treatment-free remission. We know that if you can achieve a deep molecular response, a sustained deep molecular response, that around about 40% of patients can stop therapy and remain in a complete remission. Now that's a very, very attractive achievement for a patient with CML. So the first thing I need to decide when I see a patient is how important for this patient would it be to achieve treatment-free remission. An extreme example would be a young female who wants to have a family. She'd be desperately keen to stop the drug if she possibly couldn't do it safely, and then have a planned family. The other extreme would be a 75, 80-year-old patient with significant comorbidities, where that's not really their first priority, or perhaps even their second priority. So I would put them on a scale according to their treatment-free remission. I would then consider their risk profile. And the best risk profile we have today, surprisingly enough, is the SOCAL score, which was developed in the 80s, but still holds very well for patients on TKI therapy. So my patients, where I first of all classify them according to their treatment-free remission priority, I would then classify them on a second scale of their risk profile. Patients with a high risk profile and patients with a high priority for treatment-free remission, I would prefer to use a second-generation drug, except in the fact that there are more toxicities, but I feel that I have more to gain by the more potent drug in that setting. That still leaves many patients where imatinib is a perfectly reasonable first-line option.
Which TKI would you select after failure of frontline treatment with the first or second-generation TKI?
When a patient has failed imatinib therapy, we have a choice of the second-generation drugs, nilotinib, dasatinib, and also bosutinib. And all three have advantages in different situations according to the the comorbidities of the patient that need to be considered. As I've already mentioned, if a patient was diabetic, I would tend to prefer dasatinib rather than nilotinib. If a patient had significant lung problems, I would tend to steer away from dasatinib. But certainly was a good option for some of these patients. Its toxicity that we know about is mainly gastrointestinal, and we don't at this stage have any evidence of long-term significant organ toxicity. So we have a number of choices for the patient who's failed imatinib. It's more difficult for a patient who's failed a second-generation drug. If you've failed nilotinib or if you've failed dasatinib, the likelihood of response to another second-generation drug is actually quite low. In that setting, ponatinib has a clear role. Ponatinib has been established to be far more efficacious in patients who have failed a second-generation drug. The problem with ponatinib, and the reason it's been withdrawn from the market in the US at the moment, is because there's been a number of vascular events associated with its use. However, we know that that's strongly associated with certain patient groups: older patients, patients with diabetes, patients with previous vascular events. We also know that ponatinib can actually be used at lower doses than 45 milligrams per day. So I think a combination of careful selection of patients, of selecting a dose which is the minimum that's required to achieve an adequate response, and close monitoring and trying to optimize the vascular risk factors can lead to an appropriate use of ponatinib for patients at high risk of progression.
Okay. Thank you very much.
Okay. Are we done?
Yeah.
Thanks a lot.
Okay. You too. Thank you. Bye.